you take me through a typical COVID run? Like what on a I guess if you're on a case where somebody's showing signs of COVID, what's the process of that?
So for us, it starts at the dispatch. Our dispatchers now have been given questions to ask that kind of lead you in a direction, whether it's a presumptive COVID case, a confirmed COVID case, not leaning towards a COVID case. So for us, the dispatch information is kind of the initial hint that we get about the direction that the call is going to go. And if we get information like they have difficulty breathing, they have a fever, they have a close contact with somebody who was positive for COVID, or they have a positive COVID case to test themselves, then, that kind of sets the mindset. I think Winnie talked about it a little bit, about on the way over there, if you have a strong suspicion that it's a COVID run, you're going to do things like you're going to gown up on the way there. The engine company is going to know the same information you know. So they may not go in initially. They may mask up, gown up, keep their distance, get the information that they can. If there's something life-threatening going on, the guys are going to do their job no matter what. But if it's, maybe fever, vomiting, and just not feeling right, something like that, where they can take the time to get the information and wait for the rescue to get there. So that way the contact with the person is limited to that one rescue officer, or that rescue officer and the rescue driver in the right PPE, then that's kind of what we try to shoot for, is to limit the amount of people who are in contact with that person, especially if it's a confirmed COVID case. The last thing you want to do is send 5 people into a house where there's one or more family members who have COVID, and then if there's an exposure issue, now you've taken those guys out of commission for 2 weeks, potentially. But for us, it's a normal run 99% of the time, just with extra PPE, extra precautions. The hospitals need to be made aware of the fact that you're coming in with somebody who's potentially a COVID patient or confirmed COVID patient. Right. So we always make sure that communication with the hospital is done as quickly or as soon as possible.
Around how many, I know you probably don't have exact figures, but can you give like an estimate of how many COVID patients you see a day?
So that's changed dramatically from the beginning of this to now. It was kind of a bell curve almost, where, like I said, upside down bell curve, where at the beginning we saw quite a few of them. We were transporting probably, myself personally, I can't speak for the other trucks, but I was seeing probably 3 to 4 either confirmed or suspicious COVID cases a day per shift, per 24-hour shift. And then it dropped off in kind of in the middle of the spring where nobody was going to the hospital. Right. Again, I think when he touched on that, where there was like this lull where nobody wanted to be in the hospital, they didn't have to be. So people weren't calling, even if they might have called, prior to COVID, they might have been something that was significant enough for them to call. And with the COVID precautions and everybody's anxiety about being in the hospital, the call volume kind of dropped off. And lately it's picked back up in the traditional emergencies, but also the COVID transports have ramped right back up. Now I'm probably seeing again 3 to 4 either suspicious COVID cases or confirmed COVID cases like per shift.
Right. Okay. Now, I think when I was talking with Winnie, he did say that, it is kind of indiscriminate in the, not only like it does tend to be older people, but it can be younger people as well. But also with like things like, I guess, like race and like income level. Would you agree with that? Or?
So I haven't seen a ton of that. Personally, the district that I work in is predominantly Caucasian, and so my demographic that I deal with, for the most part, has been that. I know that in other areas, in some of the cities and stuff, they've seen a big spike in COVID cases in the Hispanic community and the African American community. So I can't really speak for them because I know that in the other cities they're seeing something different than what I'm seeing.
Right.
But age hasn't seemed to play a factor in it for me. I've had 20-something-year-olds with no prior medical history who are very, very sick, and I've had 75-year-olds who called because they fell getting out of the car. You know, they hurt their ankle. They wanted to get transported, and then we find out from the hospital later on that they were COVID positive, but they had no symptoms. They weren't a suspected. They weren't a suspected COVID one from the beginning. It was a fall with an ankle injury. You know, something like that. So
Wow.
yeah.
I asked, this one's kind of tough. What is, I've heard a lot of tough stories from a lot of people about things they've seen and how it's affected them.
Yep.
Have you seen something that's kind of been, I guess, kind of horrifying or has affected you personally?
I wouldn't say horrifying. It's kind of subjective, person to person,
Right.
what you would consider horrifying. But probably the most difficult things to see are the younger people, like I said, with no medical problems, who were otherwise healthy 3 days prior, and then all of a sudden they're having trouble breathing. They can't walk. They can't, walk from one room to the next without being short of breath, and they're calling just because they're in a panic and they don't know what's happening to them. And those typically are the most difficult ones because you know how sick they are just by looking at them, but you can't really convey that to them because you don't want to put that anxiety on somebody who's already, thinks that they're dying or feels like something really bad is happening. So just trying to, I would say, the most difficult part of the whole COVID pandemic transport type thing is just being as calm as possible and reassuring as possible, because the last thing that these patients need is, seeming more nervous. I guess.
No, I think this wasn't in the original questions, but my dad did tell me that you and your wife also had COVID at one point.
Correct.
Do you mind talking about, what that was
I'll
like?
touch on it a little bit. So my own experience, it was like a 24 hours of just kind of really flu-ish type symptoms, the body aches, they're not feeling well, the kind of nausea, the headaches. It was 24 hours, it kind of came and went. It wasn't until a couple of days later that I completely lost my sense of taste and smell. Woke up in the morning, had my morning coffee like I normally do, couldn't taste it or smell it. And that was like a light bulb moment where I was like, oh, got me, okay. But I was asymptomatic otherwise at that point. As soon as I realized that happened, I drove myself over and got tested positive, and then reached out to the department, let them know what was happening. We have a protocol in place for guys who test positive or have symptoms and haven't been tested yet. Reached out to the department, and we took the steps that we had to for my quarantine. And from the day that I became symptomatic with that kind of 24-hour flu symptom type thing, I had already been quarantined. Just as a precaution with everything that's going on right now. I hadn't been tested at that point just because it went away so quickly that I kind of wrote it off as seasonal stuff. I have seasonal allergies, things like that. So it came and went so quickly, I kind of didn't think twice about it. And then I woke up with the no taste and smell, and that was that was like, go get tested. I got tested right away, had already been quarantined for 3 or 4 days. And then probably, I would say 2 or 3 days after my test came back positive, the wife became symptomatic, and hers was a little worse than mine. She had the bad flu symptoms. She had migraine, she had the nausea, body aches, the weakness. Hers lasted quite a bit longer than mine. But again, she recovered also. She's still got some kind of lingering, you would say, like headaches and nausea and body aches, kind of just like a milder flu symptom, but it's kind of lingered. It's been going on close to a month now for her, where she's still got some kind of lingering, not feeling great stuff going on.
So you guys both tested positive when? Around
the beginning of November, the first week of November. So we're a little over a month out of it.
Right.
I've been symptom free now for over a month. I had the 2-week quarantine before I was able to go back to work. The no fevers and the whole protocol that we've set forth for coming back to work.
I am curious, actually. I don't think we got into it too much with Winnie. What is the protocol for, I guess, the fire department if somebody is positive or there's a potential exposure?
So the department, as of right now, is just following the CDC guidance, which has been standard across the board. Anything that the CDC recommends at this point, I think the department follows suit and takes the most appropriate quarantine schedule to keep the people from, coming back to work before it's safe to. But also, you don't want to lose an entire department to quarantine, which, has happened in other places where you have, a large group test positive and you lose a huge percentage of your department all at once. You still need staff, but at the same time, you can't be irresponsible or unsafe bringing people back to work before it's appropriate to do so.
Right.
So that's where the department takes their guidance and their regulations right from the CDC and the state health recommendations.
I mean, do you know if they do things like contact tracing and
They do.
type of
They
thing?
do. So we follow the same contact tracing that the state does.
Mm.
When we test positive, the state contact tracer contacts you right away, no matter what.
Right.
So I was contacted by one of the state employees right away, and we went back to I think it was 3 days prior to the symptoms beginning, something like that. And then the department, we do the exact same thing. When did you work last? Who were you in contact with? Who did you work with?
Right.
And it's the same exact tracing as the state's doing, but we do it on a department level. So the department wants to know who you were in contact with, who you worked with, who were in the station with, stuff like that.
That is interesting. So like if you're you're on rescue, right?
Correct.
So
Yep.
they just like look at the truck and they're like, okay, you were working during this shift, you were
Yep.
all in the truck,
Yep.
we need you to get tested until you're negative, you can't, whatever. Or
Kind of. So the difficult part about the rescue is if I had worked even a day or two prior to my symptoms, which I hadn't, so it worked out well. It worked in my favor because there is a huge contact tracing, you would say, gap in there. Because if I had no known contacts, in my household, I was feeling good otherwise, but I had been working on the rescue up until the day I became symptomatic, then the contact tracing would have to go, that much further into potential patient contacts also, which, is a HIPAA violation, I believe. I don't know if they necessarily be able to directly reach out to each person that you're in contact with, whether it be patients, family members, otherwise.
okay, I guess in your opinion, do you think there's anything maybe, I don't know, I mean, either the government or the general public, kind of in general, could do to make, I guess, things easier with your job?
Not really at this point. I think, as overwhelmed as we are, as the system is right now, I think everybody's doing the best they can with what they have. I don't know if just adding things and giving things would make it easier necessarily. It comes down to the general public also. They, and I think the general public understands the system is kind of overwhelmed at this point.
Right.
So the best thing I would say is, and equipment-wise, we seem to be doing pretty good. We're not having the shortages we were having early on. So pretty early on in this, there was the N95, the PPE shortages.
Right.
To my knowledge, at least my own experience, it doesn't seem like we're having that shortage issue of PPE like we were at the very beginning of this. So, that's been a step in the right direction. It seems like that there's more PPE available for those who need it, and it's being allocated to the right places.
Okay. I think I also asked Winnie this, and he, I can't remember what he said, but I think a while ago I was talking with one of my neighbors, and her husband is also a first responder, or her son, and she had said that on one of the worst runs he had seen and heard about later on, I think, is that so I think a young woman came in feeling pretty fine, not too many symptoms, and then ended up dying in the hospital later that day.
Yeah.
So I think talking to Winnie, he'd said that you don't really tend to know what happens with people afterwards you drop them off, but had you heard anything like that?
No. So what a lot of our follow-up stuff happens if it's a really significant call or if it's a really kind of unusual call. That's when I would say 90% of my follow-ups have happened with doctors, because it's something that sticks out in your head that makes you go back and ask later on, hey, what happened with that person?
Right.
I think when he alluded to the arrow in the leg thing, where he said if you came in with somebody and they had an arrow through their leg, it would be more memorable to the doctors and for you.
Yeah.
So being able to go back and ask how that person made out would be easier. But if you bring somebody in who's otherwise healthy and it doesn't really there's nothing really that stands out in your mind. It's not something you think to go back and ask about. And there's so many of these, routine, medical transports that happen every day. Kind of to go back and ask about each one of them would be kind of nuts. You wouldn't follow up on every single call that you went on, and the doctors wouldn't be able to answer your questions anyways. They would have no recollection of somebody who came in, because of the ankle injury. You fell out of your car and twisted your ankle, and if they happen to pass away in the hospital later on from something crazy, then it would more than likely be after. It may have been after the ER. Maybe they were admitted, passed away in the hospital or something like that. So being able to follow up on those becomes really difficult.
Right. So I think, everything's changed with the pandemic.
Yep.
And this is kind of broad, but what about your job has specifically changed since the start of all of this?
I think the biggest change has been how we actually deal with the public on a one-to-one level. There's, more PPE involved. There's social distancing involved. We're not just kind of going into houses and, being friendly and, trying to have that personal one-on-one with the patient and the family.
Right.
Especially when you have a suspected COVID run, you have the engine company standing outside and PPE standing at a distance, getting information. That there's a real lack of personal interaction that you would otherwise have with the patient and the family that I think has not necessarily been lost, but there's definitely a limited amount of that personal one-on-one that you normally would get. In some places, the doctors have gone as far as to putting pictures of themselves on the front of the PPE because with the amount of stuff they're wearing in the hospital, especially, you can't even tell if you're talking to a man or a woman, a child, an adult, an elderly guy. You have no idea who you're talking to. So for us, it's not that extreme because we're not completely head to toe in, PPE that makes us unrecognizable. But at the same time, there is, talking to somebody through a respirator with goggles on, maybe a gown, gloves, stuff like that.
Right.
You just lose a lot of that, and they're wearing masks also. So I just think just the day-to-day interactions with the public and the patients seems to be, less personal than it would have been.
I think that's an interesting point too, because I think that's so, I don't know, the thing my mind goes to is you think about that at like a healthcare level, but I think if you look around, you also kind of see it in like society in general.
Definitely. Definitely. Everybody's in masks and keeping their distance from other people. Yeah, there's definitely a lack of intimate, personal, interactions that were otherwise completely normal.
Yeah. So I think of like, I'm a generally pretty healthy person. I don't tend to have to need, what's the word? I don't know, just needing to be picked up by a rescue.
Yeah, healthcare services, emergency services.
Yeah. I think of that as something that would be kind of out of the norm. Mm-hmm. So I think even in a normal setting, that would kind of throw me off. Now with the pandemic, I think it's easy to understand, I guess is my point, how somebody might be more adverse to you guys coming in this setting. Yeah,
you're saying people are less likely to call us?
Yeah, I guess that's kind of around what I would be.
Yeah, for things that would otherwise be normal to call for, I think people are not necessarily avoiding being taken to the hospital, but there's definitely an extra anxiety that goes along with calling and being transported to the hospital. Unfortunately, I'm sure that there's real medical emergencies that are being overlooked, or the people aren't calling when they should because of the anxiety about going to the hospital. Right. And they may be overlooking something more serious that's going on, either with them or their family members. So they're choosing to not seek treatment just out of a general fear of being in the hospital around the COVID patients.
Okay. I think I have one more question. Yeah. Okay. So, I think Winnie and I talked about it a lot, and I think he definitely talked about it more with my dad because he had more knowledge. Yeah. But so you mentioned, I think the big thing that came up was how overwhelmed the hospital system has kind of been, and how hospitals have had to go on like forget
diversion.
Diversion. Yeah. So, what's your experience been with that? I'm just curious.
It's going to be pretty similar across the board. I think as far as the rescues are concerned, the diversion, it affects everybody. it doesn't, it's not unique to one hospital or one hospital system. Everybody has to divert at some point during times like this where there's, just a huge load of people coming into the hospitals. I think the only way to alleviate some of that influx of people is to divert and, ask the rescues to go elsewhere.
Right.
For a certain period of time. But it's not unique to any one place or one hospital. I think everybody has to do it at some point, because right now the influx of people into the hospitals also isn't unique to one hospital or one area. It's just kind of widespread, and not even on a state level, on a national level, everybody's kind of overwhelmed. So they kind of have to do something to give the emergency rooms a break. And the easiest way to do that is to just stop. You can't stop people from walking up to the hospital and seeking treatment. If somebody walks into a hospital, and they need to be treated, you can't be turned away at the door from the hospital. But you can, slow the influx of rescues coming in, maybe, especially in a really busy hospital system like you have in the city, where you have rescues constantly coming. That slowing that down makes a huge impact in then being able to catch up and get these people to the appropriate places, whether it be to the ICU or whether they're going to be admitted. Giving them that time to move these people to where they need to be kind of helps catch up in a way.
Okay. I keep thinking of more questions. I'm sorry. So I think I didn't touch on this too much with Winnie, but I feel like as a first responder, like, there's got to be your job. I think it's fair to say, hopefully not biased, considering my dad is one, but your job is pretty hard. I guess difficult compared to some other jobs out there. So I think with this, does it make things any more worrisome, stressful? How does this affect your well-being, I guess?
Just speaking for myself, obviously, I don't think it's changed much. The only, I would say, extra anxiety I have about my job as a whole right now would be, catching something at work, bringing it home, getting somebody else sick.
Right.
I worry less about myself in the whole scheme of things. I worry more about, what if I get my wife sick? What if I get my niece sick? My brother, my mother, sister, father, whoever. So on a day-to-day level, I don't really worry about the job any more than I would any other day. But the only extra piece of that puzzle for me would be, what happens if I get something and it doesn't make me sick, but it makes somebody else sick? So that's always a concern.
Yeah. So another question I had was, I am curious, have you seen anything like the symptoms that young people get versus, I think, symptoms you might find more common among older people? Is there anything like that happening?
I don't think there's anything that is about COVID that I've seen personally that's super age specific. But I know Winnie touched on the pulmonary embolism thing and stuff like yesterday. I do know of another one recently that I saw who, it was a younger person, otherwise healthy, kind of came down with the same type of flu symptoms. And then, as the weeks going on, the flu symptoms kind of lingered, but then they developed the pulmonary embolisms, which is, I think, what Winnie was trying to talk about yesterday. That's one of the things that kind of has been sneaking up on people, because these aren't people that have clotting disorders necessarily, or even cardiac issues, and they're developing these blood clots in their lungs, and the fear is the blood clot going somewhere else, going to the brain, going to the heart. And the particular one that comes to mind recently, the person is I believe still very sick, because even though the COVID symptoms, the traditional COVID like flu-like symptoms, the respiratory stuff, has kind of subsided, the clots are still present, which still creates like a very real danger in their day-to-day life.
Right.
Having to be on blood thinners and, having to be scanned frequently and get imaging done to make sure that the clots haven't multiplied or gone somewhere else, is a kind of a real day-to-day thing that these people are having to deal with.
Right. So COVID almost, so that's from COVID, correct?
Yeah, that's the assumption would be that it was from COVID. There's prior to the COVID symptoms, this person, didn't have any known clotting disorders or cardiac issues or anything like that.
Right.
And then they developed COVID, and the respiratory symptoms kind of lingered, and getting scanned and getting, further tests after the COVID symptoms kind of didn't go away. They start to find these other things that are happening to these people. And that's kind of one of the things where the 99%, survivability rate that kind of we talk about with the COVID as a whole isn't painting the whole picture.
Right.
So if 1% of the people who catch COVID, pass away from it, it's still a huge number. But there's still a huge number of people who may survive it, but wind up with these kind of either temporary or lifelong disabilities or health problems that, they survived it and, they didn't die from COVID. But, this is a person who was otherwise healthy who survived COVID, quote unquote, but still has some very serious medical stuff going on.
Right.
So
I think that's a really interesting point, because if you think about, like, I think my favorite part of the interview with Winnie was, I was so blown away when he said, like, I said, like, other people, it was me. I was the one blown away when he was like, when we get a vaccine, it's going to be a while before all this goes away.
Yeah.
So I think it
is
is
talking about normal, going
back
to normal. Yeah.
So it is interesting when you think about that, and you think, like, for some people, the way this goes, like, it's never going to be completely normal.
No,
like, people.
We have no idea. We've only seen 9 months.
Right.
We only have 9 months of data to reference for this. This is completely new for science and for the medical community. So we have no idea what's going to happen 10 years from now with people who've had COVID. They could have health problems earlier in life that they may not have gotten. We have no idea. And it's unfortunately that's going to be a waiting game. There's no way of knowing what's going to come down the line for these people. And there's people who already have developed these medical problems, or complications from COVID that they may have to deal with now for the rest of their lives. So it's not as cut and dry as surviving or not surviving COVID. It has a lot to do with the other things that go along with it, the other things that develop that you survived, but you now have to live with.
Right.
And with the vaccine, everybody wants it to be, the answer to the problem, and everybody can go back to normal tomorrow, and everybody gets vaccinated and everybody goes back to normal. But realistically, things take time, and depending on the efficacy of the vaccine, how many people want to get it, and stuff like that, and it's completely dependent on the direction everything goes. Do the regulations and stuff, and the mask wearing, the distancing, does that make a big impact when you add it to the vaccines that are coming down the line? So I don't think there's any way to tell when normal will be back for everybody, but I think it's going to be a while. It doesn't feel like it's going to be soon.
One of the things that Winnie touched on, and when Chris was asking you about responding to runs, and the question I always got when you show up at the house and everyone says, I called for a rescue. Why is the engine here?
Yep.
Explain to people, like, and especially now we're talking about minimizing exposure.
Correct.
To people.
Yeah.
Why does an engine go? To explain to people.
So the main reason I think that the engine is so important for EMS calls is the time it takes to get on scene. So just for an example, where we work, there's 4 rescues covering an entire city. So, but there's 10 engines. So when you have, the engines are districts are smaller, they're quicker to respond to the houses. So 9 times out of 10, unless it's a call in your own district with an engine that's in the same house as you, I work in a station where there's an engine and a rescue. So if we go out together, we're both in quarters and we respond on a call, we typically will get there at the same time. Often that isn't the case. So the engine is usually the first one to get on scene, make first contact with the patient, and then report whatever they find to the rescue that's coming in. The other reason that's important is you don't always know what you're going to. You can get as much information from the dispatch as you can, but there's always going to be a variable that you can't account for when you show up on scene. You could get to the scene, and the patient could be on the third story of the house, not able to walk. They're going to have to be carried all the way down and out. And that's something you just don't account for. It's something the dispatchers wouldn't ask. Hey, what floor of the house are you on?
Yeah.
Are you able to walk down the stairs? How much do you weigh?
Right.
Things like that. You can't ask people, you don't ask people that on the phone. It's not a normal question. If somebody calls and says, I have abdominal pain, you say, okay, now they screen for COVID in addition to the regular questions that they would ask. They ask you your address and they dispatch trucks.
Right.
And then that's kind of the end of it.
Right.
And we get there and we have to find out, all these extra steps that may be in place just to get the person from the house to the rescue.
And I just get him down the stairs. And I so often like, what, you need all these guys to carry him? And I was not very politically correct. I'm like, well, you didn't lift him.
Right.
Why didn't you carry him down?
Right. Right.
There's one person hurt here.
Yeah. And I mean, a rescue crew is just two people. So, two people can only do so much. And especially with these, multi-story houses, when you have somebody on an upper floor, it's not as easy as it seems to just pick somebody up and carry them down, 3 or 4 flights of stairs. And just for the safety factor of having maybe a person behind the bottom person carrying, having that back person to just kind of watch the stairs, tell the person, there's another stair coming up, or there's a short stair coming up, or, things like that. So having that extra set of eyes and extra set of hands is invaluable for a medical, even regular medical call.
I mean, even just having extra people, because there's 4 sides to every story.
Mm-hmm.
There's the person who called.
Yep.
Typically the wife. My husband, he can't breathe.
Mm-hmm.
And you get there, and the husband's like, I'm fine.
Yeah. Yeah.
But in that, talking and sizing up the whole scene, what really is going on up to this point of like, he might have been complaining of shortness of breath for a long time.
Yeah.
And she was nagging him to go.
Yep.
He doesn't want to go.
Yeah.
So in that, having the extra guys was, and some, one of the extra guys was like, hey, just so you know, this.
Yeah, he doesn't want to go to the hospital.
She doesn't want to
go to the hospital. It happens a lot with we get third-party callers.
Yeah.
Somebody's on the phone with a relative or a friend, and they make a comment, their chest hurts, and they hang up, and they don't think anything of it. And then that friend, concerned for the safety of their friend or family, whoever it is, they call 911 for that person. So we'll show up to a house, a third-party caller, for chest pain, and you get to the house, and that person doesn't even know you're coming. They didn't want you to come. They didn't call for you. They didn't ask for anybody. They didn't ask for any help. And you show up to the house, and they have no idea why you're there.
Right.
And it happens.
And now you're in a tough spot.
Yeah.
Now you're in a tough spot because you're doing your assessment.
Right.
Because, that third person, if they were overreacting, which sometimes happens,
Can happen.
And on the other side where that person was right, and now
maybe you find something.
Talk to that person to convince them, and your assessment.
Yeah.
It's all about patient assessment.
Right. And that starts from the minute you walk up to the person.
I have a question too.
Shoot.
So how it's kind of specific. How have you had anything like that with like a third person calling for somebody and saying, hey, my uncle's had COVID symptoms. He doesn't think he has had this. Can you go and...
I haven't had any third-party call, COVID-related third-party calls. A lot of the COVID stuff right now is a person who has either gotten worse symptoms or new symptoms who's calling because they want to get seen because, they're concerned.
Mm-hmm.
I haven't had any third-party call. A lot of our third-party call stuff is usually something kind of that gets mentioned in conversation and the other person, rightfully so, trying to look out for the person, will call.
Right.
But as far as COVID stuff, I don't think I've had a lot of COVID calls where it came from a third party and the person had no idea who was showing up to the house.
I think another question I have too is, in your experience, have you had, because I think it's been proven you can get it twice.
Mm-hmm.
Have you had anything like that where you show up to a house and they're like, yeah, I had COVID back in when this all started, and now I've got it again?
I haven't seen that yet.
Okay.
I've heard that there's been plenty of cases where people have gotten it a second time.
Mm-hmm.
I haven't personally seen any yet. I think maybe department-wide, I think we've had maybe a case where a relative had got it a second time, which was unusual because that was kind of the first time that we had heard of, a repeat, especially in a short amount of time from after they got better and then they caught it again, tested positive again. So,
what about changing change in mental status. Have you come across any patients that might be fever, change in mental status? Watching the news, certain people talk about, I was so confused, I was delirious, I didn't know what was going on. Have you come across any of those cases? And in that, how do you handle that situation of change in mental status, which is that's a hard thing to deal with to begin with.
It is. The most helpful thing with a patient who's altered in some way is a family member or somebody that can help you with them. Because a lot of times when you have somebody who's altered, they aren't the ones that called.
Right. So
it's going to be somebody that's in the house more than likely who called. And if it's an anxiety issue, if it's whatever it is, if they're altered for some reason, I mean, there's a million things that it could be. The hardest part is narrowing it down. You got to rule out the big stuff first. You got to rule out the strokes. You know what I mean? You rule out cardiac issues, obviously, like that, with neurological issues. And then I wouldn't say that COVID is really a high priority right now for altered mental status patients. I'm not thinking like stroke, cardiac, COVID, just because on a personal level, I can only go based on what I've seen so far. I haven't seen a lot of COVID-related altered mental status calls. 90% of the COVID runs I've seen have been some kind of respiratory or flu-like symptoms. So those are pretty straightforward. Those people can tell you what's wrong with them, or you can see it when you walk up to them. So,
patient assessment starts from the call. The time from the dispatch.
From the dispatch.
Okay, what's the address?
Mm-hmm.
Going there, showing up at the house.
Yeah.
Looking at the house.
Yeah, you look at the house, you look at the person.
From the moment I walk up.
Yeah.
And looking at the house, looking at how many cars in the driveway, how many have flat tires and stuff, and kind of get an idea of is this person.
Yeah.
Does this look like these people take care of themselves to begin with?
Yeah, sure.
And then, but that, has that changed at all?
I don't think so. No, I think that just out of habit, you tend to develop a way of assessing a scene from the minute you walk up to it. And I don't think that's changed, in 8 months, just because it's kind of a ingrained, habitual thing that you do on every single call. You kind of size up the call the same way every time over the course of 10 years, just because, maybe the PPE's changed or the distancing has changed or there's a new illness or virus or something going on. I don't think it would change the way that I walk up and assess a scene or a patient.
Are you seeing more family members get COVID? So that you go pick up someone one day and then like a week later you're picking up someone from the same house?
So I haven't seen it as much in the just a single household, but in the congregate care setting, the nursing homes, the group homes and stuff like that, it seems like we've had a bit of these little explosions inside these congregate care places where you'll have a patient who's positive and then a week later, you get notified by fire alarm and a dispatch that address has 7, COVID positive patients. So that's been fairly common in the nursing home settings and the group home settings and stuff like that.
So when you bring a patient to the hospital, not many people call 911. When you get to the hospital, what happens? Like what's the whole process of from you pull up and walking in, like?
So for a regular medical patient, a non-suspected COVID patient or non-confirmed COVID patient, it's pretty straightforward. It's just like you would see on TV. Wheel the stretcher in, you go in, you check in with the nurse, and they give you a room. They assign you a room. You go to your room, you drop the patient off. You give your report to that nurse that's going to be taking care of that patient directly, or the doctor, whoever it is that's going to be caring for that person. The COVID patients, there's the extra steps. There's the notifying the hospital, ahead of time, which you typically will do with any call. You'll notify the hospital ahead of time. Some hospitals take advantage of that, notification system more than others. So there's that. But with the COVID patients, the pre-hospital notification is huge because they want to know that you're coming in, and they also, if they need somewhere to put the person, so most of the hospitals now are doing some kind of, isolated room where that person's going to go into that room and they're going to have one nurse, and, it may have doors instead of blind or curtains. So they need to know that they have to find somewhere to put this person when they get there. And then when you actually get to the hospital, that's changed a little bit. Initially, we were doing like a pre-hospital notification, and then when you arrived at the hospital, you would notify them, and they would come out and actually get the person from you at the rescue, and you wouldn't actually enter the hospital with the person. Now things have changed a little bit, where some of the hospitals are allowing you to come in with the patient on the stretcher like we normally would, but they're having you go directly to whatever the isolation room is that you're going to go to. And other hospitals are still having you wait outside. So that's the only real difference is, the walking directly into the hospital with the patient thing. Some hospitals are still doing that, but with limitations. They may clear out an area for you to go through first and make sure there's not a bunch of other people sitting around the area you're about to walk through with this person who's, maybe coughing and is COVID positive. So that's the only real difference. The notification is the big thing, because you don't want to you certainly don't want to show up on a hospital doorstep with a person who's COVID positive and they have nowhere to put this person.
Right.
And now you're stuck with them in the truck.
Right.
You certainly can't put somebody in a hallway or, in a wheelchair in the waiting room who you either know is COVID positive or strongly suspect is COVID positive.
How is the staffing holding up at the hospital in terms of their actions? I mean, there's an article the other day, like Care New England's trying to fill 250 positions.
Yeah.
Someone has to be there.
Correct.
Someone has to be working. That means people are having to work extra shifts.
Yeah.
How's that working? You've seen increased stress in the hospital staff, like fatigue, not fatigue, but just
burnout.
Yeah.
Yeah, I mean, I can't speak for anybody else and how they are dealing with this on a personal level, but, it seems like the system is strained. It seems like these people are, working more than they, may have ever worked in a hospital setting. And, that it's stressful. I can't imagine going from, a 3 or 4 patient, ratio to maybe having to bump that up a patient or 2. That's a lot for one person to kind of manage. And especially maybe a new nurse coming right out of school, I can't even imagine what it's like to come out of school and walk straight into a pandemic situation in a hospital. Where some of the more seasoned nurses and doctors kind of already have a rhythm in the emergency room setting and the ED setting, where a new nurse has no rhythm or direction or kind of routine that they're used to. So they're kind of getting thrown right into the lion's den with it.
And at the hospitals, how has that affected? You say, because you can't have visitors.
Correct.
A good friend of mine's mother
Mm-hmm.
is in the hospital right now.
Okay.
Trying to get into an ICU bed.
Yeah.
She's sick. She's in a holding pattern.
Yeah.
Trying to get, they're not ignoring her.
Right.
But
there's physically
she can't get there.
Right.
But for the family, very tight-knit family,
Mm-hmm.
can't get to see her and
Right.
getting information. Are you seeing how?
Yeah, I
What
think
sort of
that's
stuff are you seeing about that?
so that's kind of way after the fact for us. We're long gone by the time this stuff occurs. But it seems like that's kind of a story that's playing out all over the country.
But how do you handle that when you pick up the when you respond to a scene?
Oh, when a family member wants to come with you or something.
Oh, yeah, and
Mhm.
and how do you handle? Because that is a part of the interaction with the family.
It is.
We're going to take good care of them.
Yeah.
And to just whisk them away.
Right.
And how do you handle that situation? Explain to the family can't go to the hospital.
Right.
And
I think especially lately, now that we're kind of getting kind of deep into this thing, a lot of the people are very understanding that this isn't, a time when the hospitals are allowing visitors, you can't come with us in the rescue, stuff like that. People seem like they're responding better to that now than they did at the beginning. I think the more difficult kind of demographic has been like the elderly, married 60 years, it's just the two of them in the house, and you're taking the husband or the
I'm
wife.
coming with them.
And you're taking the husband or the wife,
not.
right? You're taking them to the hospital, and the other person, number one, wants to go with them just to comfort them, but number two, they're having the fear about the COVID in the hospital and everything that's going on. They may think that this is the last time they're ever going to see this person that they've been married to for 60 years, maybe, and that fear and that anxiety about that, what's next and what's going to happen over the next 2 days after this person gets taken by rescue. I think that plays a huge part in it, and that's kind of the demographic where we're seeing the most difficult, trying to explain to them that they can't go to the hospital. has probably been the most difficult with that demographic, because it's just not something that they want to do. They don't want to let this person just go. A year ago, if you were to take somebody to the hospital, people will just hand you their baby and tell you, save my baby or take my baby to the hospital or whatever the case is. People have a lot of trust in the emergency services, and I think that trust is still there. But with the COVID and everything going on right now, I think the anxiety about that, leaving that person, in the hands of other people, is a little, I want to say, less reassuring than it used to be. But I think that people have a more difficult time now just being able to say, okay, I'll come by to the hospital a little bit and check on you, because you just can't do it.
You talk about anxiety. Are you seeing more behavioral ones from anxiety, depression, suicide, stress, domestic abuse?
Yeah.
Are you seeing it in the general population? Are you seeing an increase in tension and trouble? And
personally, as far as just speaking for the rescue and myself, I haven't seen really an increase in that. I think there was a lot of information kind of early on that the police were seeing an increase and stuff like that. And I think the lockdowns and stuff like that, tensions are high, people are anxious, people are losing their jobs, people are losing their businesses, stuff like that.
I mean, there's so much of that. Exactly. There's a lot of increased stress, like you said, people losing their jobs and money and this and that.
Yeah.
And people that might have had issues in the past, having a hard time falling off the wagon and stuff, but you're not really seeing much of that yet.
I don't feel like, just me personally, on a day-to-day basis on the rescue, I haven't seen really a huge jump in any of that. Like the alcohol use, the drug use, the domestic stuff, I haven't seen it really in my little microcosm of the rescue rate.
That's
world.
right.
Yeah.
So I mean, he's looking at everything. All right, good.
Yeah.
Small steps.
I have a question too. So are you seeing, would you say less of that maybe even, or?
No, I don't feel like it's changed much.
Okay.
I
So it's just steady, stay the same.
That side of things has pretty much been the same for us. I feel like.